So welcome, ladies and gentlemen. Thank you very much for your time this evening and for joining us with our hand dermatitis webinar. What I'd like to do, if I could, is to firstly introduce our speaker, Dr. Ryan Cruz. So Ryan graduated from the University of Melbourne in 2009 with honours. He was awarded the Australasian College of Dermatologists Herman Lawrence Prize in Dermatology and completed a Bachelor of Medical Science in Hair Disorders. Dr. Cruz has a broad range of experience working with tertiary hospitals in Australia and the United Kingdom, including consulting positions at the Royal Melbourne Hospital and the Skin Health Institute. In addition to the Royal Melbourne Hospital, Dr. Cruz practices across 3 private dermatology clinics in Melbourne's southeast. His research has been published in leading medical journals and presented at peak international conferences. In recent years, Dr. Cruz was awarded the Paul Eddington Scholarship from the Skin and Cancer Foundation and the FC Florence bequest from the Australian College of Dermatologists and the Victorian Fellowship, which is a state government fund, to undertake clinical fellowship in the role of immunosuppression of the skin with a particular focus on bone marrow transplant patients. He's worked at King's College Hospital, NHS Trust in London, and is now the clinical lead in the bone marrow transplant dermatology at the Royal Melbourne Hospital. And he's also passionate about teaching general practitioners, nurses and medical students. So that's obviously why we're here today. And also I'd like to acknowledge and thank the support of La Roche-Posay and CeraMidebased, who basically have helped coordinate this today and organised Ryan for this presentation. Just to explain how today's going to be going, we've got a video presentation we're about to present to you, which is about 19 minutes long, which covers the description, the causes, the management options, hand care advice, ideal properties of moisturizer, common Q&As. And then at the end of playing that video, we're then going to be going into our own live Q&A session. So as I mentioned before, down the very bottom of your screen on your Zoom panel is a Q&A panel. If you click on that, you can type in your questions. If you're working off an iPad or a tablet, that option is typically on the top right-hand side of your screen. So Ryan, thank you very much for your time. And we'll start by playing the video.
Hello, and welcome to this educational video regarding hand dermatitis. My name is Dr. Ryan Cruz, and I'm a specialist dermatologist based in the southeastern suburbs of Melbourne, Victoria. I also work at the Royal Melbourne Hospital and at the Skin Health Institute. I love the skin and all things dermatology, but my interest area is particularly that of eczema. I also love treating general dermatological issues including acne, rosacea, psoriasis, skin cancer, and hair loss. The topic of today's discussion will mainly be focused on that of hand eczema, and particularly given the current climate, we're seeing increasing rates of this. As healthcare professionals, it's something that's close to my own heart, and I'm sure yours at home. So what I'd like to impart today is a range of practical tips on how to recognise, prevent, and manage hand eczema. The main objectives of today's video are to educate and provide knowledge regarding hand dermatitis and how to manage this in a private setting, a public setting, and in the community. I'd like to provide realistic recommendations on how to maintain a healthy skin barrier to improve patient outcomes. By the end of this session, I hope that those of you at home will know how to manage and understand the underlying condition and identify the causes behind hand dermatitis. I'd like you to understand the range of management options that exists and how to maximise the skin barrier. Hand dermatitis is one of the most common conditions that I see in clinical practice. It can present both in the acute phase and the chronic inflammatory phase. It's a skin condition that will affect not only the palmar aspects of the hands, but also the dorsal aspect of the hands, and can affect up to 15% of the population. It is of course much more common in healthcare providers, hairdressers, bakers, and anyone who is required to wash their hands multiple times per day. It accounts for up to 35% of all eczema that we see in the community and is very common, particularly in young adult females. However, it can occur at any age, including childhood, and it is particularly common in patients who suffer from pre-existing atopic eczema. Eczema or dermatitis is the triad between a genetic predisposition, particularly with regards to the skin barrier, an immune hypersensitivity syndrome, and the environment. It can generally be divided into 3 types: atopic or endogenous eczema, irritant contact dermatitis, and allergic contact dermatitis. However, all three conditions can occur simultaneously and are not mutually exclusive. When we look at the intrinsic factors that predispose to eczema or hand dermatitis, the most common one includes an atopic tendency. That means a genetic predisposition towards asthma, seasonal rhinitis or hay fever, and atopic dermatitis. This can be genetically linked to other autoimmune conditions, including alopecia, thyroid dysfunction, and celiac disease, but by far and away, the atopic triad is the most common. The genetic element of the predisposition towards hand dermatitis relates to the skin barrier deficit and the fact that those who are genetically predetermined to have low levels of ceramides and filaggrin are much more likely to allow irritants and aggravants to enter the skin and create and stimulate inflammation. In a similar manner, if you are predisposed to having a hypersensitive allergic immune system, you will release greater amounts of histamine and pro-inflammatory cytokines in response to the allergens and irritants that are allowed to enter the skin. The extrinsic factors or exogenous factors behind eczema are many and varied, and this is a general group of chemicals that will trigger irritation and inflammation of the skin both of the body and of the hands, depending on what's exposed. So thinking more generally about irritant contact dermatitis, I'm referring to a general group of ingredients and chemicals that can aggravate the skin barrier and trigger dermatitis. The most common irritants include soaps or surfactants, alkaline agents, excessive exposure to water, particularly hot water, alcohol-based hand sanitizers or hand rubs, cleaning detergents, harsh chemicals, and any product that contains significant alcohol. Even abrasive clothing can be considered an irritant. Finally, a big group is that of occupational exposures, particularly healthcare workers, those in the food preparation industry, bakers, as well as hairdressers and those in the beauty industry. These are groups of people who are all exposed to various different types of chemicals within their occupation on an everyday basis. Allergens are a more specific group of chemicals to which the body's immune system can react and create inflammation. These can include nickel, found in many types of jewellery, rings, necklaces and earrings, cosmetic products, including certain preservatives, fragrances and hair dyes, house dust mite, which is found in all bedding and clothing, animal dander, such as cat and dog dander, pollens, grasses and moulds. Bacteria and viruses also play a significant role when it comes to dermatitis in general. We all have endogenous bacteria that live on our skin, as well as viruses. However, it's when the skin barrier is damaged that these bugs get into the skin and create and aggravate inflammation. Particularly, Staphylococcus aureus can work as a super antigen, enhancing the inflammatory response and aggravating dermatitis. All sorts of pathogens, whether it be viruses, bacteria and fungi, can aggravate inflammation within the skin, and therefore maintaining a healthy skin barrier is the most important way of preventing secondary skin infection. Finally, certain medications can often aggravate the skin barrier, and they're medications that I myself prescribe every day, including oral retinoids, which dry the skin, but the use of other topical products such as topical retinoids, alpha hydroxy acids, beta hydroxy acids, and certain chemotherapeutic agents can often aggravate the skin barrier as well. When discussing and thinking about eczema, the first and foremost component to be considered is that of the barrier, the skin barrier, which is the most important aspect of the skin in reference to preventing irritant contact dermatitis, allergic contact dermatitis, and atopic eczema. But what do we mean by the skin barrier? Well, actually, the most important aspect of the skin is the very final frontier of the skin, the stratum corneum, which is only a few micron thick. The stratum corneum is composed of dead epithelial cells that are held together through intercellular lipids, including cholesterol and ceramides, that hold the skin together like the bricks of a house. When the bricks of the house aren't held together with good cement, the bricks separate, and thereby we lose water through transepidermal water loss, and we allow irritants and allergens to enter, creating and enhancing skin inflammation. The skin barrier is destroyed through all of the factors that we've already discussed, including heat and dryness, the use of harsh chemicals, particularly detergents. When all of these are allowed to happen, the loss of lipids and ceramide enhances the loss of water, which exacerbates the itch-scratch cycle and worsens inflammation. So how does hand dermatitis actually present in the clinical situation? Well, in my experience, there are two phases of hand dermatitis, the acute and the chronic phase. In the acute setting, the acute signs of inflammation present, including itch, redness or erythema, swelling and discomfort. When all of these occur, they can actually become secondarily infected as well, and you may even see blistering or weeping. Acute hand eczema is also known as dyshydrotic eczema or pompholyx, so one may see small vesicles or fluid-filled pockets arising in the skin. This is indeed hand eczema. After acute dermatitis is allowed to progress for weeks to months, the chronic signs of inflammation ensue. And this includes thickening of the skin, specifically lichenification, itch and flakiness as well as dryness. So when should you refer a patient with hand dermatitis to a specialist dermatologist? There are two key times a patient should be referred. The first is when you consider an allergic contact dermatitis to be part of the patient's diagnosis. Allergic contact dermatitis is quite commonly diagnosed on the patch testing, which identifies delayed type hypersensitivity reactions. The second time is well before the patient's function is impaired, as patients may require systemic therapies or ultraviolet light therapies to help improve the state of their skin. Irritant contact dermatitis and allergic contact dermatitis can often look very similar and can present simultaneously. There are subtle differences, however, in how to differentiate the two clinically. Allergic contact dermatitis is a type 4 delayed type hypersensitivity reaction. In English, this means that it occurs several days after the exposure to the chemical in question. It's when the immune system is primed to react specifically to a chemical. Allergic contact dermatitis will present with the classic signs of eczema, including redness, itch, dryness and discomfort, but this may take several days to occur. There's often a parallel between where the skin has been exposed to the chemical in question and the development of eczema. However, allergic contact dermatitis can also spread beyond the sites that have been exposed. This can be quite tricky to identify. Irritant contact dermatitis can be slightly more insidious in its nature. It can present subtly in the dorsal hands and particularly the web spaces with dryness, redness and discomfort. Itch may occur, but doesn't always, and patients may report simply having uncomfortable hands or burning, stinging or soreness, particularly when exposed to other chemicals, including alcohol-based hand gels. Importantly, irritant contact dermatitis does not necessarily need the topical therapies, including topical corticosteroids. The mainstay of treatment for irritant contact dermatitis is the use of a soap-free cleanser and regular emollients or moisturising. Irritant contact dermatitis will occur to any patient, regardless of their genetic predisposition, if they're exposed to the same chemical, including water, on a recurrent basis. Patients who tend to wash their hands in excess of 10 or 20 times per day, with or without soap, inevitably develop irritant contact dermatitis. The impact of hand dermatitis on one's quality of life cannot be underestimated. It's often subsumed amongst the patient's eczema if they have it elsewhere, or in patients who do live with hand dermatitis as an isolated form of eczema, they just live with it and get on with life. However, if you probe these patients, they will commonly comment on the fact that they wake up in the middle of the night scratching, therefore they have quite interrupted sleep. It can have significant effect on their mood and their mental health. It can affect their activities of daily living, whether it be making their children's lunches in the morning, washing the dishes at night, engaging with family and friends, and can affect other people as they notice patients scratching, they notice sores, broken skin on their hands, and this can be quite off-putting. Prevention is the key when it comes to hand dermatitis, and this requires early recognition and intervention to prevent the condition before it has a chance to become chronic. Top-line prevention is the key. That means the use of regular hand emollients to prevent the loss of water and prevent irritants and allergens entering the skin barrier, causing inflammation. Importantly, when we have a defective skin barrier, this allows bacteria, viruses and fungi to penetrate the skin more easily, and it's therefore much more easily to transfer these pathogens to other people and to objects. Thereby, enhancing the skin barrier is one of the most important ways of preventing the spread of infection. The two most basic principles when it comes to treatment of hand dermatitis includes the use of a soap-free cleanser or synthetic detergent at all times. Patients may believe that they require harsh soaps or antibacterial washes to help prevent the spread of infection. This has been disproven. The use of a synthetic detergent or soap-free wash is just as good as using an antimicrobial hand wash. It simply requires the patient to expose their hands to lukewarm water for a minimum of 20 seconds. It is the running water and the action of slight surfactants on the skin that help wash away pathogens. The second tenet of hand dermatitis prevention and management is the use of an excellent hand moisturizer, and this needs to be applied no less than 4 to 6 times per day, particularly after exposure to water, whether it be water from washing your hands after the bathroom, before food preparation, after patting animals, or for whenever the hands are exposed to water, including hand washing and clothes washing. When it comes to the specific management of hand dermatitis, topical corticosteroids are often the first line of therapy after a soap-free cleanser and moisturizer are instituted. The potency of the topical corticosteroid should be tailored to the severity of the patient's eczema. For mild to moderate cases of hand dermatitis, lower potency topical corticosteroids may be required. But for more moderate to severe cases, ultrapotent topical corticosteroids may be indicated. At the very end of the severe spectrum, we have systemic corticosteroids and systemic immunosuppressant agents. But it's really important to remember that regardless of the severity of hand dermatitis, using an appropriate hand moisturizer or an emollient multiple times per day is absolutely critical. There are a number of simple hand care tips that can help not only prevent hand dermatitis, but also manage it if one does develop it. The most important aspect of this is not to expose the hands to water that's too hot or running for too long. A simple 20-second hand wash is usually enough to remove all the dirt and grime as well as the pathogens that may cause secondary infection. Lukewarm water should be used, not blistering hot water, as this will only aggravate hand dermatitis. Soap-free cleansers have been proven to be as effective as antimicrobial hand washes. It is not important to use something that contains benzalkonium chloride, triclosan, or chlorhexidine. A soap-free or synthetic detergent is equally as effective when preventing against bacterial infection and viral infection. After hand washing, it is important to dry the hands thoroughly, and this can be either with paper towel that's then discarded or through cloth that's then washed. Moisturizer must be applied after hand washing for more hydration and to replenish the natural skin oils that have been removed. These can be applied multiple times per day, including 10-20 times per day as necessary, and can be used after the application of an alcohol-based hand rub. Nails should be kept short and clean, and this will help prevent the harbouring of bacteria and fungi under the nails and transmitting it to other patients. The use of protective gloves cannot be underestimated, and this particularly is relevant in the home setting when undertaking dishwashing and clothes washing. In the clinical setting, it's whenever is clinically appropriate. So what makes the perfect hand moisturiser? From my point of view, it's really important that hand moisturisers are simple but effective. This means they should not be heavily fragranced and contain a truckload of preservatives. The minimalist formulas are often the best. Hand moisturisers that restore the skin barrier are critical. These should be both hydrating and therefore contain humectants such as glycerin or hyaluronic acid, but also replenish the natural lipids that formulate the skin barrier and the stratum corneum. This includes ceramides, fatty acids and sterols. The moisturiser should be able to effectively deliver these active ingredients rather than simply being evaporated off into the air. The skin barrier also needs to be enhanced through a layer of protection. Silicone-based ingredients, including white soft paraffin, are also very important to help provide that final barrier between the skin and the external environment. Finally, it's a moisturiser that the patient wants to use. Moisturisers that are too thick or greasy are unlikely to enhance compliance. These are products that need to be used multiple times per day, and therefore patients should be happy to use them. So what are the main differential diagnoses when it comes to hand dermatitis? Whilst hand dermatitis is incredibly common, there are a number of other differential diagnoses that should be considered. And these include psoriasiform dermatitis, which is a variant of psoriasis, palmoplantar psoriasis, another type of psoriasis, tinea manus, or fungal infection of the hand, and hand, foot and mouth disease, which is a viral infection. It's important to remember that tinea manus will often affect one hand only in an isolated manner. And a tip is to examine the patient's feet. If you can see signs of tinea affecting the feet and only one hand, topical antifungals treatments are often more appropriate. So what is the optimal way of using moisturisers as an adjunct? The simplest answer is hand moisturisers should be used as an adjunct to active treatment as many times as possible per day. There's no such thing as over-moisturising, particularly when the hands are exposed to water and detergents. How often should hand moisturisers be used? Hand moisturisers should be used as much as possible. As frequently as the patient is exposed to water, a hand moisturiser should be used. So what are wet wraps for hands? Wet wraps are probably the most effective way of managing mild, moderate and severe hand dermatitis. It's a 3-step process. The first step is the application of a medicated treatment, such as the topical corticosteroid. The second step is use of the best hand moisturiser the patient can access, whether it be CeraVe hand cream or whichever the patient has at home that is occlusive. The third step is to use wet cotton gloves. These are easily purchased from any supermarket and should be used in lukewarm water. The patient should remove excess water and apply the gloves directly on top of the skin that already has the steroid and the moisturiser applied. Ideally, wet wraps are applied at night for a minimum of 2 hours. The use of wet wraps every night, 7 days in a row, will see huge improvement in hand dermatitis.
Awesome. All right, so we're back. Thank you very much, Ryan, for obviously putting that together, and a very informative session. As I said, we're going to be doing some Q&A. So as I said, if you've got any questions, which we have quite a lot, which is good, there's a Q&A box at the bottom of your panel. So just click on that box, type in your question, and I'll obviously do my very, very best to answer it. And just to let everyone know that you'll be getting a copy of this recording. So as far as sharing it with your peers, colleagues, staff, or reviewing it again, you will get a copy of this, which we'll be sending out to you tomorrow. Anyway, so Ryan, if I could just start with a few questions, if I could, please. So what's the impact of topical steroids on the synthesis of lipids within the skin barrier?
Thanks very much, Paul, and hopefully everyone found that helpful. I've already read a couple of the questions that have come through, but before we get stuck into those, your question's a really important one. What we know is that everyone's aware of the dermal effects of chronic topical corticosteroid usage over time, and that includes the classic signs of skin atrophy, which reflects reduction in collagen and elastin, telangiectasia, increase in blood vessels, and striae or stretch marks. What many people aren't quite aware of is the inhibitive effects on the skin barrier that topical corticosteroids do have. So importantly, we know that topical corticosteroids play a very critical role as anti-inflammatory. So they down titrate the expression of pro-inflammatory cytokines. However, they also impact the stratum corneum's natural lipid synthesis. And this includes ceramides, it includes free fatty acids and cholesterol. So in doing so, they almost paradoxically can increase transepidermal water loss. Now, by all means, this does not mean that we shouldn't be using topical corticosteroids. It just means that they should not be used by themselves. They should always be paired with a lipid-respecting physiologic moisturizer as well, because of these potentially deleterious effects that they have on the epidermis.
Awesome. And does prevention include food allergens as well?
Yeah, so I noticed this question came up, and it was a very interesting one. There's a lot of controversy regarding food allergens and eczema, and I'll try to make my answer as succinct as I can. But essentially, food allergies and eczema have only a tenuous link in the adult population. When we think about food allergies, we're primarily talking about type 1 hypersensitivity reactions. So that means hives or urticaria. It is quite uncommon for food in the adult population to drive eczema, and specifically to drive hand dermatitis, which is what we're talking about tonight. It's quite different when we're thinking about a pediatric population, particularly children under the age of 1, whereby a food allergy, for example, to cow's milk protein, to peanut or soy, may actually trigger a delayed type hypersensitivity or a type 4 reaction, whereby it may actually be aggravating eczema. So the question really is, what age is the patient and what is the presentation of their eczema? Because if we're talking specifically about hand dermatitis, it is incredibly uncommon that food will be triggering it. And again, I want to emphasize that's both food that the patient is consuming orally or food that they are touching. The slight caveat to that is there are certain types of hand eczemas that may be triggered by food handling. A common example is that of garlic or pumpkin skin, where people can, funnily enough, have quite a specific type 4 allergy or type 4 hypersensitivity. So that is actually a form of allergic contact dermatitis. And these patients who develop hand dermatitis to specific foods, whenever they handle a specific food without gloves, should be referred for patch testing.
Awesome, thank you. Next question. Is it possible for ceramide-based formulations to have a steroid-sparing effect on the skin?
Yeah, indeed. So when I manage a patient with eczema, the primary goal, of course, is to induce remission, that is through an aggressive onslaught of topical corticosteroid paired with a good barrier moisturizer, and a physiologic lipid-based moisturizer would be ideal. Our goal is always then to reduce the topical corticosteroid usage to second daily, then third daily, perhaps reducing it to a weekend regimen or twice weekly application. That will obviously prevent the long-term effects of topical corticosteroids on the skin. The main aim is to increase the flare-free periods. Now, this can be achieved through the regular use of moisturizing every day on the days that they're not using topical corticosteroids. And this has been shown histologically, whereby particularly ceramide-based moisturizers can help reduce transepidermal water loss, and in doing so, actually downregulate the inflammatory cascade. So it's not as simple as preventing dehydration. It's the combination of reduction of dehydration or transepidermal water loss, as well as the down titration of inflammatory cytokines. And this has been shown quite nicely in a number of studies. It does not mean that you can completely remove the need for topical corticosteroids, though in some milder cases of eczema, this may in fact be possible. But in the majority of cases that are moderate to severe disease, some topical steroid, perhaps just twice per week, is a really fantastic way of preventing recurrent flares.
Beautiful. Another question, thoughts on savalon on hands in conjunction with emollients?
Yeah, so savalon, for those who are not familiar with it, is the combination of chlorhexidine and a cetramide, I think, in a cream. It's essentially an antibacterial. The question is, well, first of all, people can certainly develop allergies to chlorhexidine by a type 4 delayed type or allergic contact dermatitis. So it's not something that I'm keen on patients using on a regular basis. The other question is, well, what is the purpose of it? Is it to prevent bacterial infections, viral infections or transmission, or is it to prevent secondary hand dermatitis and bacterial infection of the hands? In my opinion, the best way of preventing bacterial and or viral infections of the hands is to maintain the skin barrier. And so by far and away, I don't subscribe to using topical antibacterial agents on a regular basis, because if the hand barrier itself is intact, there's no need for that. In terms of transmitting sort of bacteria and viruses to other patients, again, it's not something I think is necessary if adequate hand hygiene is undertaken. And the reality is that 70% ethanol, which is contained in most antimicrobial hand gels or antibacterial hand gels, have got a very, very high broad spectrum antibacterial and antiviral activity. A lot of people will say, but doesn't that actually aggravate hand dermatitis? And the question is, yes, it will, because it's a very drying and harsh chemical. The key is to ensure that the hand barrier is absolutely as perfect as it can be through the use of a soap-free cleanser, really fantastic moisturizing, such that the alcohol-based hand gel does not sting or trigger significant degradation of the hand barrier. So I hope that that answer helps, that answers that question.
Excellent, thank you. Do emollients play a role in treating hand I'm just conscious you've already got the word, and you can see the questions as well.
That's right, that's Pomflix.
I'm not a clinician, so I'm going to trip over any word that's got crazy made-up names.
No problem. So, for your education, Pomflix is just the fancy name that's given to what we refer to as dyshydrotic eczema. It refers to the bubbly hand eczema that people can get. So tiny little vesicles or fluid-filled spots on the hands. It can also occur on the feet. Pomflix is simply what we use the word a morphology of eczema. It's just the way eczema presents on glabrous skin. Glabrous skin is the skin on the palms and off the soles of the feet. So when eczema appears on the face or on the body, the arms and the legs, it's red, patchy, scaly skin. When it appears on the hands, it may appear as these little vesicles. It's just a form of eczema and absolutely requires hand emollient. So like any form of eczema, a good hand cream is an integral part of the treatment process. It's not just the topical corticosteroid, it's the concurrent use of a naturally lipid-respecting barrier cream as well. So absolutely.
Okay. In your experience, does hand barrier emollient treatment, especially in patients with compromised skin barrier, prevent viral penetration?
Yes, I read this question earlier, and I think it's a very interesting question. The truth is, I don't think we have enough evidence for me to give you an honest, specific answer about, for example, COVID-19 or specific viruses. What I can say that in general terms, we know that when the skin barrier is intact, we have fewer infections of any type. So fewer viral infections such as HSV or VZV, so eczema herpeticum. We have fewer bacterial infections such as Staphylococcus or Streptococcus. So it makes sense that in maintaining a hand barrier, the skin barrier will reduce penetration of other viruses such as COVID-19. I just don't have the evidence to say that that's specifically true because it's such a new virus, I guess, that we're now facing.
No, excellent, thank you for that. Is there an increased incidence of hand dermatitis to those with diabetes, obesity, or heavy smokers?
So in clinical practice, I don't believe that diabetes or obesity particularly increase the risk of hand dermatitis, but certainly in smokers, I feel that, and this is not evidence-based, so please, I don't take this as 100% gospel, but in smokers, my clinical experience is that the general hand hygiene, the lack of emollients, the dryness, the pro-inflammatory effects that smoking can have can trigger, or not trigger, but certainly aggravate hand dermatitis. I don't have good evidence to make a comment about diabetes or obesity for hand dermatitis, though, no.
Okay. And is there any specific amount of time that needs to be left between hand sanitization and moisturizing?
No, there isn't. So hand sanitation, so if I'm to be specific with an alcohol-based hand rub, that actually evaporates. It's such a high alcohol content that it evaporates within seconds. So no, you can put that in a few seconds later, put on your hand moisturizer, and you will not be reducing the efficacy of the hand sanitizing gel. Okay.
And the other one says, patients report stress flares up the dermatitis. I mean, how common is this, I suppose?
Very common. Yeah, absolutely very common. So a common line that I use in my clinical practice is that stress can aggravate many skin conditions. It causes very few of them. But certainly it can aggravate hand dermatitis, it can aggravate atopic dermatitis, psoriasis. So yeah, absolutely. In times of high stress, you're going to have a primed immune system, an overactive immune system. So yes, absolutely, that can be true.
And what about chronic general skin itch? Should we do the same diagnosis as hand dermatitis?
We have to be careful. So itch it's a very common symptom and it's not a specific symptom. So itch can be seen in many different conditions. The trickiest patient is that who has itch without rash, which can be a little bit of a diagnostic dilemma or conundrum. I'm loath to ever blame stress alone as the cause for itch. unless I have completely excluded absolutely everything else. And I'm fairly convinced that this is what I would refer to as a neuropathic itch, so a nerve-based itch. But so as I mentioned earlier, itch can aggravate a lot of conditions. So whether it's eczema-caused itch, whether it's a drug rash itch, psoriatic itch, whatever it is, chronic kidney disease. But I'm loath to make that diagnosis that it's purely stress causing the itch unless I have exhausted absolutely everything else. It's a diagnosis of exclusion.
Okay. Sometimes we use antibiotics when the dermatitis is not responding to the topical cortisol. What antibiotics would you suggest? Is it staph always?
Okay, so I guess I have not a problem, but I think you have to be very careful. So the use of oral antibiotics in eczema is really only indicated when there is clear signs of secondary infection. I do see it quite commonly that patients are prescribed antibiotics when they have eczema, and when you actually probe, well, did they do anything? Often the answer is no. So diagnosing cutaneous infection can be tricky. So I'll absolutely acknowledge that. I always will swab the skin, look for the signs of infection. I'm a big believer in dilute bleach baths. So any patients that I see will often hear about dilute bleach baths, which are excellent antibacterial and antiviral agents. And so it's not so common that I prescribe oral antibiotics for eczema of any type, unless it's clearly they've got a folliculitis, so pustules are seen, or it's clearly weeping, in which case it may need antibiotics. But in terms of which ones I usually would use a broad spectrum antibiotic such as cefalexin. That would be often my go-to in patients who are truly cephalosporin allergic, erythromycin, which would be my second choice.
Okay, beautiful. Would you like to clarify whether moisturizer or moisture applied on top of a steroid cream over the lesion? And if yes, what is the mechanism to use it in this way?
Okay, so I think I've understood the question, but essentially, yes, the way that I prescribe the topical corticosteroid and moisturizer is in that order. So first topical corticosteroid followed by moisturizer. And you'll find that this is variable depending on which dermatologist you speak to or has made the recommendation. But this is my technique. So my order is usually cleansing with a soap-free cleanser, whether that's in the shower or at the hand basin, if we're talking about hands, followed by the use of a topical corticosteroid, followed by the moisturizer. And my thinking is that we are trapping in the topical corticosteroid with the barrier cream. We're increasing the natural potency without actually occluding it unless we need to occlude it. And to me, it just makes more sense to do it in that.
What are the advantages of using wet wrapping compared to using simple Glad wrap or something like that?
Okay, so it cut out slightly, but I think you said what are the advantages? That's okay. What are the advantages of using wet wraps?
Yeah, versus Glad wrap or something, cheap and simple.
Great question. So if you've ever tried to use Glad wrap or Chucks or any other kind of sheet on the hands, it's just practically terrible. It's just really difficult for patients. It's messy, it's sticky, and patients hate it. The far easier way of doing it is to purchase cotton gloves, which I also learned recently. You can even purchase at basic pharmacies, Chemist Warehouse, the discount chemist, anywhere. And they're very inexpensive and they're just so easy. They often come in a packet of 3. And because they're cotton, you can soak them quite easily and they fit onto the hand. It's one size fits all. It's just so much easier and less messy and much more practical.
Yeah, I'm sure if you've got the condition, you'll probably do anything to actually have it fixed as well, I would suggest. What do you do after patch testing and find an allergen that can't be removed?
It's a good question. So, look, it's pretty rare to genuinely find an allergic contact allergen that you can't exclude somehow. I think it's about minimization, and it's a very broad question because there are so many different types of allergens, whether it's preservatives, fragrances, adhesives, medicaments. I think most patients, particularly let's say in the hairdressing industry, where there is a high rate of allergic contact dermatitis, will often say, look, they know which dyes they can and can't use, which gloves they can and can't use. And if all else fails from an occupational sense, or in an occupational setting, it's about redeployment. That's all that you can do. On a personal or domestic level, it's about minimization, I guess.
Yeah. And do you avoid latex and protective gloves when patients have active dermatitis?
No. So I want to clarify latex allergy and then answer the second part of this question. So latex allergy, a true latex allergy, is a type 1 hypersensitivity reaction, which means it causes an almost immediate or within a few minutes of exposure red rash of the hands. It is not a delayed type hypersensitivity. It's not something that's going to appear after days to weeks like an allergic contact dermatitis will. So unless someone has a proven allergy to latex, which you can prove through a RAST blood test, you don't have to avoid latex gloves. And patients who have a true type 1 allergy will know that, will know it off themselves, the rash that they get, or will have had it confirmed on a blood test. In terms of the gloves, therefore, no, it's actually use of gloves in patients who have hand dermatitis is actually very important, because what we're trying to do is repair the skin barrier, which has been destroyed through the use of through chemicals or through their allergic contact dermatitis, and we sort of need to rest the skin or rest the hands. And so I will use, particularly in food preparation, for example, if the patient prefers to, they can use a nitrile glove, but there's really no reason to avoid latex unless they have a true latex allergy.
Okay, and there's been a few questions around ointments or creams. Is there a particular preference, I suppose, once again? For
yeah, sure. So in the hierarchy of topical corticosteroids, ointments are above creams due to the slightly increased potency. When it comes to the hands and the feet, I do choose ointments. They are absorbed better. They're slightly more potent than the creams. When it comes to eczema elsewhere, again, the hierarchy is for ointments versus creams. The truth is, when you've ever used a thick, greasy ointment on the skin, they're not very pleasant to use. And so this is something I learned for years as a registrar, that we should be using ointments. What in reality, patients, the compliance can be lowered if they simply don't like the texture. So I ask my patients, when we're talking about eczema elsewhere, what do you prefer, ointment or cream? Which one will you use? Some really don't mind and they don't care, in which case I will choose an ointment. But if they do, I'll choose a cream in that sense. The risk of a cream is that it will contain some preservatives, because it is an emulsion which has some water in it, and it is theoretically possible that they can develop an allergy to the preservative. That's the risk, if you will.
Awesome. Ryan, thank you very much for your time. I'll be very honest, ladies and gentlemen, I've got 31 more unanswered questions, and I'm really struggling about who I should pick, and I've obviously gone from the top all the way down. So if you don't mind, Ryan, I might actually get some of those, and if you have the opportunity to, there'll be obviously common questions in amongst that group. But look, I really appreciate your time. We're actually 15 minutes later than we originally wanted to conclude the session, but obviously it's been very popular and very well appreciated, and I've had a lot of very positive comments also in this. So firstly, I want to thank you for your time. I also just wanted to let everybody know, I said you're going to get a recording of this. We will, as I said, get some more information regarding some of the other questions. But if you would also, when we close this, you'll have an opportunity to give us some feedback. And also, if you want to leave your contact details, we can organise La Roche-Posay or a CeraVe rep to come and actually bring you samples of the products, and also a full-size sunscreen as well. So take the opportunity to get, once again, samples and learn more about the products. But I think that the key thing is, thank you so much for sharing your knowledge today. It's been awesome. I really have appreciated it. It's interesting, there's also an opportunity if you leave other topics you might be interested in. I've had obviously somebody say we'd love to do something on psoriasis. So I think obviously general dermatology is something which, as you know, 10% of GPs see as part of their clinical practice. And it is an area of great thirst and knowledge. And I really do appreciate your time. And also, once again, La Roche-Posay and CeraVe for help coordinating this with us tonight. So,
no problems. Thanks, Paul. And look, I've had a look through some of these questions that are popping through. There are some really fantastic questions. I'm really sorry that there's not enough time tonight. I'd be very, very happy to do this again. Just let me know, because there are some really great questions that are coming through, but anytime.
Awesome. All right. Thank you very much for your time tonight, Ryan. I really appreciate it. And I also thank everybody for their time this evening. And we look forward to seeing you very, very soon. Thank you very much.
Thank you. Good night.